Okay, thanks everybody for joining. We're going to get started here. This is Carol from STS. This is the Society of Thoracic Surgeons Congenital Heart Surgery Database User Group call for June 7th. Leanne had to be out today to care for some sick kiddos and doggos in her family. So I'm going to do my best to go through the slides that she prepared, along with Chastity, who will more than likely be the person who shares the most relevant information. On the call with us today from STS, it's myself, Chastity, Leslie, and Melinda. From IQVIA, we have Michelle, Joe, Jean, and Dr. Meyer has joined us. Thank you for joining us. We will go ahead and get started. For the user group call today, just welcome and introductions, and then STS update, IQVIA update, and then your user feedback and questions. Liz has already put a question in the chat box. I'll just ask that if anybody has questions, please put them in the Q&A or use the raised hand function so we can go ahead and unmute you, and you can make sure you unmute yourself on your side and then share your question with us. For STS updates, the June training manual has been posted. The 2021 harvest analysis update, the analysis results are expected to be early summer, prior to the spring 2022 harvest close. We don't have a date yet, but we're expecting hopefully sometime in July that we will have that harvest analysis reported out to sites. The spring 2022 harvest close will occur after the 2021 harvest analysis is available for you all to review. It's TBD. The task force is discussion at the end of the month to decide on a date once we have more of an official date regarding the 2021 harvest analysis report release. Once we have a final date, we'll share that timeline with everyone. And again, it is pending on the fall 2021 harvest analysis report. 2022 audit update. Email notifications will be sent out to the 10% of selected sites on Monday, June 13th. So the notification will be sent to your primary data contact and your surgeon representative. Be sure to keep an eye out for those emails. Sometimes they might go into your spam folder. So check on Monday. Actually, check on Tuesday because they'll probably be sent sometime Monday and going out in batches. And then important for the 2022 audit is the 30-day status verification for the MT30 stat, which is the 30-day status, and the MT database discharge status. STS leadership has instructed us to require the documentation used to code those fields 100% of the cases. If you do not provide that documentation, you will complete the audit, but you will fail the audit without 100% of verification provided to the audit company. Failing the audit means that you would be re-audited within the next 2 years. What this means is for these two fields, the MT30 stat and the MT database discharge status, is that where you code the status of the patient at those times, there has to be some type of tracking log, or if it's outside of your EHR, some type of tracking log as to why you coded things the way that you coded. So if it was a phone call with the patient, if you checked the medical record, if you called the surgeon's office or the primary office, or whatever, that if you had to check, say a patient's older and they have social media, you check social media pages, whatever it was to verify the status at that time needs to be documented in some form so that and you'll need to send that to the audit company for all of your patients that are audited. Chastity, do you have anything to add for that?
Yes, I'm happy to add a little bit. I think that you made all the good points, but the point is, for 30-day status verification, we need to be providing where we obtained the 30-day status of alive or dead. So if it's in your EHR, that's fine and you're done. You don't have anything else to document because you have a document within your EHR that says the patient is alive or dead. For those patients that perhaps traveled to you or came from afar or has an outside cardiologist, whatever, then you need to show proof of where you got it from. I know sometimes, in my own program, I have to call an outside cardiologist or a different care provider. And even sometimes we followed up with parents themselves of the patients. And so I keep a log of this that says, on June 7th at 10 a.m., talk to mom. Mom says, patient is alive. Whatever, no complications, no readmission, something along those lines, where I have proof that I did that. And so that's at a minimum of what is acceptable for audit. Anytime you can get true source verification, maybe somebody would share a record with your hospital or something, a pediatrician's visit or a cardiology visit on the outside. That's, of course, the gold standard to have actual source documentation. But otherwise, you do need to say where you obtained this information and on what day and how you obtained it. So called mom, talk to cardiologist, whatever. Does that make sense?
Yeah, great. Thank you very much. That's perfect. Thank you, Chastity. Before we move on to the next slide, I know there's one question here from Cindy on the date range for the audit, and I'll just take this now. So since we're on the topic, we will be auditing. So this audit will be for 2022. We will be auditing the last half of 2020 and the first half of 2021. So from July 1st, 2020, and I'm talking so I don't get this date wrong. July 1st, 2020 through June 30th, 2021. So harvests that have already occurred for OR dates within the harvest that have already occurred. So we don't have to worry about waiting for this next harvest to occur before we pull the data. So again, the dates will be July 1st, 2020 through June 30th, 2021. And Dawn put a tip in there for everybody if you just wanted to check that out. Okay, thanks, Chastity. And moving on. The other item here is that we are planning for AQO 2020 AQO, which will be in Providence, Rhode Island, October 26th through the 28th. The congenital date is Friday, October 28th. It will be dedicated to congenital for that whole day. We will have hybrid meeting offer both in person, and there will be a virtual option. The in-person option will have benefits that come with that. Of course, the virtual options, more information will be provided to you about what will be available and when the information would be available. And then AQO submissions open this month. In planning from AQO, we do have a couple questions that we would like for you to fill out using the Survey Monkey regarding topics that you would like to be presented on, taught on. And then also regarding speakers, if you're interested in speaking or know somebody who would be interested in speaking. This email there was an email sent out. I think the link was sent out in the webinar reminder yesterday. And then this is the link here, or you can scan that QR code with your phone. Hopefully it'll work. And the link should pop up on your phone. I think you just open your camera and the link will pop up. And I think that's it. I'll leave that up for a few seconds if anybody wanted to do that. Don't do the survey during the webinar though. We want your full undivided attention. And then IQVIA, Joe, I'm going to hand it over to you.
Great, thank you, Carol. Nothing new from us to speak, but just some reminders of some items that we're working on. SCS 8311. The reports are currently showing records that have had any updates by means of second upload submission. For those records that have not had submission updates after the 1-year criteria was met, they're not affected. But for records that have been updated, our report is for some reason not displaying those if they're missing the MT365 stat variable. So that is on the missing variable report and the harvest summary report. We are working to get that resolved. But for the time being, just be aware that not all records are being captured there. And then a couple updates regarding items we're working on for the primary procedure mismatch report, SCS 8289. Procedure code 1772 for conduit placement other will be updated to remove the stat score assignment since it was deemed not eligible for assignment. And then SCS 8301, there is an issue where the primary procedure report is incorrectly indicating that code 600 for valve replacement pulmonic PVR should be the primary procedure when there is another code with a higher stat score available on the selected code list. And that's it for me this week.
Wonderful. Thanks, Joe. And please note that submitted tickets are currently under review, and the IQVIA support team will follow up and or target a release for confirmation. And then the any upcoming items to be included in a release will be posted on the notification section. And then any analysis report questions, please reach out to IQVIA Tech Support at CHSD Tech Support at IQVIA.com. And then STS or DCRI will be looped in when tickets are escalated to tier 2 and as needed. Any questions, reach out to Leanne on the database, or if you have operational questions about updating your contact list or contract issues, please reach out to the STSDB at sts.org. Next monthly webinar will be June 21st at 12 p.m. Central Time. And then the monthly webinar, there was a user group call in here that was planned for July 5th. We are going to cancel that since that is the week of 4th of July, and most folks take that as a nice vacation week. So we will be canceling the July 5th user group call. So our next, after June 21st, our next monthly webinar will be June 19th, same time, 12 p.m. Central. And we're going to go to questions, and I'm going to go back to this. Uh-oh, my mouse works. Oh, brother. Go back to this if you wanted to do that data manager survey and the QR code. A few questions here for you. I'll go with this one first, Chastity. It says, how would you code the Starnes procedure for Epstein's anomaly?
Yes, absolutely. So there's not an Epstein's anomaly repair code specifically in the database. And so what you're going to use is procedure code 465, Epstein's repair. Now, I know if you use the long list, you can get some greater granularity around that actual Starnes procedure, but in the STS database, in the short list and what's going to be analyzed will just be procedure code 465, Epstein's repair.
Great, thank you. And then Liz is asking, will 365-day also be required? And I think you're talking about the audited, if 365 will be required for the audited variables. I don't know that. I have to pull up the audit list. I'm not sure of the variables that are audited. Unless Chastity or Leslie, you know off the top of your head.
I don't believe that 365-day is a part of the audit.
Okay.
Not at this time.
Thank you. And I just want to show, make my screen a little bit smaller here. Show a couple of things on the website. We have one other question in the mail in the Q&A. It says, recently I learned that some procedures performed well on ECMO should be coded as CPB cardiovascular if the ECMO circuit is acting as bypass. How do you capture perfusion data in that scenario, or do you just enter 0?
Kelly, there are a couple questions related to this already posted in the training manual, but essentially you fill out the information as best you can related to perfusion. You probably don't have all the information, and you can leave those blank or put in zeros where appropriate.
Great, thanks. Thanks, Chastity. Okay, so a couple things I want to show here. The first thing is the AQO page. So this is sts.org. Under meetings, if you go to live courses, you'll see the 2022 Advances in Quality and Outcomes of Data Managers meeting. When you click on this link, there's an interest list button here. Filling out this form will keep you updated with the most up-to-date, updated with the most up-to-date, with the most up-to-date information. So when abstract submissions open, when registration opens, things like that. So I suggest if you want it to go to this page to fill it out, it would probably be very helpful to you to be in the know when updates are available. The other thing I wanted to point out is on the registries page under STS National Database. If you scroll down on this page, you'll find information about the audit here. This is under important resources. It's the third from the last link. under audit, you're going to see the audit policy. This audit policy is being updated with additional information regarding that 100%, 100% required submission of your documentation for the 30-day mortality and database discharge fields that should be posted within the coming days. And then the congenital heart surgery database information is here. So this is this site. These are your letters that will be sent out if you wanted to check those out once you receive STS notification that you're going to be audited, and then the audit process video about how to upload your information to CRS, who is our third-party audit company. And then if you have any questions, you can reach out to Emily Conrad via email. Her email is econrad@sts.org, or you could use this link here. And did we have anything else to talk about, Chastity?
I don't believe so. I think we hit everything unless there are more questions in the chat.
Hey, Chastity, that's Dr. Meyer. In regard to that tricuspid valve closure, for whatever it's worth, we've used the procedure code 480, which is valve closure tricuspid, parenthesis, exclusion, univentricular approach, close parenthesis. So I think, I don't think this quite is correct, at least in my interpretation, to use the Epstein's repair code.
Interesting. Okay. So maybe we should submit this question to the core group so we can have a discussion around that, because in the long list mapping, everything mapped when you do some of the other repairs, it all maps back to 465. So it's interesting.
Yeah, I think I agree. I think we ought to reassess that.
Okay, well, let's bring that to the core group for discussion. So we can get on the same page for everybody and provide clarification in an upcoming webinar and in the training manual. Thank you, Dr. Meyer. And then Liz notices that there is not an option for loss to follow-up. When this happens, how would you respond? That would be the coding of unknown, correct, Chastity?
Correct. That unfortunately you can't say lost to follow-up. It's unknown. You don't know if they are alive or dead at 30 days.
Right, and in your documentation for your site, you would say that you attempted to contact the patient and that you were unable to successfully contact them, and the ways that you tried to do that. That unknown is not an option. Which field are you talking about, Liz? Let's pull it up. Liz, if you just want to put what field you're talking about in the Q&A, we can pull it up. Oh, mortality info. Are you talking, well, you wouldn't have a date of last follow-up for this field, right? For last follow-up mortality status, if you didn't have the date of last follow-up, that would be the date. You would know if the patient was dead or alive at that time. And sorry for this scrolling, everybody. I wish there was a simpler way. I don't know that there's any, there's no book. I wish that there was a way we could maybe put some bookmarks in these GCFs in the future. We'll have to work on that. Okay, we're getting there. Hold on. So patient, thank you. So I think on these fields, we have the unknown here. So your status at 30 days. So if your last follow-up was the field from up above was coded prior to 30 days, then your status at 30 days after surgery, you were unable to reach out, get a hold of that patient or get their vital status, you would code unknown here. So I hope that helps. Kelly's asking, could you show where the document is again on the website for the audit policy? Sure can. So under, just go back to the homepage here of sts.org. If you go to registries, STS National Database, and then scroll down on this page under Important Resources. The third link from the bottom here is Audits. And this is the audit policy. So it'll open up. This one has not yet been updated for the 2022 year. It will be updated in the coming week or so. So that's where you find it. And then Chastity, do you want to take Dawn's, or do you just want to bring this back?
Oh, Dawn, along the guidelines of Epstein's repair, yes, absolutely. To get an accurate count of Epstein's anomaly of the tricuspid valve, use code Epstein's repair. So again, we'll discuss this in the core group to make sure we have very clear guidance that if you did a specific procedure for Epstein's repair, which code should you use?
Right.
We will address that.
We don't want to keep talking about something and cause confusion. So it's best if we let the core group and surgeons talk about it and then provide clear instructions for any updates that need to occur.
And that's the same with her next question. We've been following this guidance, adding the valve closure as a secondary procedure. Yes.
Thanks, Dawn. Is there an option for unknown with the 30-day readmission? Well, let's pull it up and see. So under the, let's make that, you guys don't have to, I'll put loops on. Under the complications is the unplanned readmission to the hospital within 30 days of surgery or intervention. It's one of the codes for complications, the field complications. And
there's also a readmit 30 days after discharge field as well.
Yeah. And that's yes or no. So I guess if you're getting the patient's mortality status of being alive, then you're going to answer the readmission. If you don't know the patient's mortality status at database discharge if you mark it as unknown, then you would not be able to fill out this field. So the unknown is handled in the parent field to that. So the 30-day status is a required field. So if you have any unknowns, it will show as missing data. I don't believe it does. I believe it's going to show as unknown. So you'll need to check your participant dashboard for the 30-day status field and verify those that have unknown marked are correct.
Carol, it's Leslie. I think for the purposes of like what's missing for your 2% and whether or not you can submit, unknown is treated as missing.
Oh, thank you. In the missing variable field, in the missing variable report.
Like on your eligibility report.
Unknown is counted as missing for some of those variables.
Right.
I think in the missing table, IQVIA may parse out whose were missing versus whose were unknown, like whose were blank versus whose were unknown. But when it comes to your 2% missing, Leslie's right, like the unknown and missing are the same thing.
And it's going to be under this primary procedure mismatch and mortality eligibility summary report.
Yes, for the mortality eligibility summary, the 30-day will show up there.
I like to investigate.
Fair, it's good.
Let's see what happens. It's going to take a second to load, of course.
So that's the mismatch. So you want to go down to the bottom to the next tab. There you go, to op type 1 and 2. Yep.
Okay. Oh, there it is. Look at that, everybody. Amazing. Okay, op types 1 and 2 case eligibility summary. So you have your surgery year, the surgical dates that are included from that year. So for this harvest, it was July, because we analyzed 4 years worth of data. We did the last 6 months of 2016, first 6 months of 2020, and then the 3 full years in between. And then you have your total numbers of records that occur within that time frame. So you can, these are op types 1 and 2. So you can verify this against your vendor software If you have a third-party vendor, you can verify that, running internal reports and also against your OR logs to make sure that your op types 1 and 2 cases equal this number for this time frame, numbers of ineligible. And then if you wanted to make this, so I don't really care for the scrolling, especially because I have a Mac, and when I scroll back on my mouse, it sends me back a page. But you can use that, scroll down again here, that was the second tab. You can use this double arrow here to make it bigger. And then it's your, thanks Leslie for pointing this out, it's the percent missing or unknown, so it would be included in here. And this includes, Leslie, does this include all of the mortality fields that are used for the 2% missingness, or is it, do you know what goes in here?
I think this one is, I think there's 2 of them. Your database discharge status and your 30-day status. Is that right? Whatever it is that the fields that go into the, to whether or not you get into the analytic report. If you had data there and you clicked on it, it will show you like a list of which cases are included at the bottom and then which field is actually missing or unknown.
Oh, very good. Thank you.
Mm-hmm. And then Carol, I might have missed it, but can you clarify, is this new going forward with audits, or does this include the current audit year, like for people who will be notified shortly?
It includes the current audit year for 2020.
Okay. Thank you.
Yeah, of course. Thank you. Learn something new every time. So it's good. We should probably spend one of the upcoming webinars prior to the spring harvest close. We should probably spend a webinar going through all of these reports page by page to show folks, you know, how to really make this work for them in cleaning up their data and what all of it means. I don't know if we've done a dedicated webinar to that yet, but it'll probably be helpful. I think, would you agree, Leslie and Chastity, we can do it together?
Oh, yes. And we've done it before, but it's been probably since last fall. So it's probably a good idea to revisit.
Yeah. Maybe we could plan that for the June monthly webinar.
Okay.
So we have it and it's recorded, and then as folks are, you know, as we release the 2021 report and folks are starting to get anxious for the next harvest close, it's recorded and available. I think that would be great.
That sounds good.
Yeah, thank you. And I don't have any other questions coming in. Anybody have anything? Oh, I see an attendee with their hand raised, Kelly Brown. Let's see. Okay, Kelly, go ahead.
Hi, I have a question about the 365-day mortality status. I know that's not an audited field yet, and I anticipate sometime in the future that may be. Our center struggles with capturing this. We find that, you know, we've contacted patients 2, 3 times, 4 times, and we're not getting an answer. Are there any thoughts on how to handle this? Can we look at perhaps, you know, we've contacted them 3 times and like defaulting the field to alive, or not counting that patient in analysis. I don't know if any other centers are struggling with this or if they have any other ideas.
Can I offer what we do?
Yes, please. Thank you.
And it, you know, we're still not anywhere near 100%. I mean, far from it, but we try to get a cell phone number and email address on every patient, you know, while they're here. Some people seem to respond better to text than to an email. Others are the other way around. But that doesn't, you don't get 100% response rate. So the other things that we do is we will contact both their pediatrician and their referring cardiologist particularly for those outside of our local area. And, there may be some privacy concerns or other things like that. But if you have the name and birth date and you just ask for the last time they were seen at the pediatrician's office or the cardiologist's office, apparently that's okay from a HIPAA compliance standpoint. So, if they were seen in the office, I think it's pretty reasonable assumption to assume they were alive. And in the context of, why would we want to be doing this? I think what everyone's coming around to is that, short-term mortality is not enough. And, that's the way it's always been in the past. But I think, realistically, we need to be thinking about, what's the outcome over, the next year, 5 years, 10 years, because that's really what the parents want to know. They want to know, what's my child's chance of surviving and growing up, or, getting to be a teenager or whatever. That number one. And then number two, in the grand scheme of things, that's probably a better outcome variable over a longer period of time for us to be tracking. And unfortunately, the history of congenital heart surgery is marked by, a number of undertakings that, seem like great ideas initially, and we didn't really find out how ineffective our treatments were until sometime later on. And it was only through this follow-up information over a prolonged period of time that we started figuring out, for instance, that atrial level repairs for transposition weren't so good, and we ought to be doing arterial switches. That's a long time in the past, but it was that kind of follow-up information that was really important in moving the field away from, an accepted paradigm for treatment, to do something different. That's the context for all of this. And I think there are some parallel efforts that are going on at the STS level, where we might, by accessing National Death Index data, we can fill in again some of those, missing pieces, really, for the long-term outcome for our patients. And again, part of the general context for this is, if you look over the last several years at the mortality rate, the mortality rates are sort of 2 or 3% in that range. And, that's probably we should all be glad about that, because the patients are doing better. But that's short term. What if we're getting a bunch of patients to survive, get out of the hospital, and then they die, between that discharge and the time they were supposed to come back? We found that out in the hypoplast experience. We were losing patients from interstage deaths. So it's that sort of general context is what has led the task force database, congenital database task force, to try introduce this 1-year follow-up field, so you can understand this is not just coming from left field. There's a real rationale behind it.
Thanks, Dr. Meyer. I appreciate that. I do agree that 1-year follow-up is an important measure. I think one of my other questions then is, can we, since we are struggling with finding these patients and we are using email and text and calling and, can we use social media to confirm that we've, found a patient that's alive? Is that a viable solution as well?
I personally don't see any reason why not. why you couldn't, use that as another data source, assuming, that it's reliable and, that's not in some ways, inaccurate, but I think, I'll tell you, for me, when I get Christmas cards from old patients and stuff like that, that data goes in the database right there. So, that the patient was alive, and, of course that's, exception probably, because not every patient sends you, a Christmas card or something. But I do think, as long as you have something that's reasonable, I don't think anybody's, going to bring some audit hammer down on you because you found it on Facebook or something that somebody was alive and here's a picture dated whatever, of the child in the swimming pool or something.
All right. Thank you. I appreciate your feedback.
Yeah, thank you, Dr. Meyer. Thanks, Kelly. And then we have Tony, you have your hand raised. You can go ahead.
Carol,
Okay.
while we're waiting for Tony, I just wanted to point out too, for, sort of from the employee side, it's a really important conversation to have with leadership now, especially as we look at 2 and 5 year follow-up, that this is a part of our job and this takes time to make these phone calls and make sure that, you're really talking about what kind of effort that requires, because sometimes that's additional resources for all of these patients, especially over that long a period of time.
That's a really great point, Leslie. Okay, we're going to take a question from Joyce here. It says, if you are the data manager calling or texting the family, what do you say or ask? My NP has always done it, but it gets to be a lot for her, especially with the new fields coming. So I'm going to have to help at some point.
Yeah, I guess what we do, we have a standardized thing, we ask, I don't know, half a dozen questions or something in a text, and you just have to click yes, no, and there are things like, is your child having, trouble growing, or is your child, had been readmitted to the hospital, or, things like that. Or when was your child last seen by your pediatrician or a pediatric cardiologist? And usually, because we do certainly, like everyone else, have a few patients that we find out that's the way we find out that they've expired. The families will usually, or at least it's been our experience, that they'll usually respond in some way to let you know that their child has died. But it's not, this isn't perfect. And I don't want to underestimate the amount of time and effort it takes. We have a group of patients that we never get follow-up on who come from overseas, and even with texts and email addresses and stuff like that, we don't always have the ability to find them. So I can't imagine the threshold is going to be anywhere close to the 30-day mortality threshold, at least not in the immediately foreseeable future. But I do think we hope everyone would recognize the importance of really trying to gather this data so that, we can find out how the patients are doing after they leave the hospital, or the 30-day outcome data. I can tell you from our own experience, there's a measurable attrition after the first 30 days, particularly in patients, obviously, with palliated congenital heart disease.
Thank you, Dr. Meyer. Hey, everybody, it's Dr. Subramanian. Sorry, I had some difficulty coming in as a panelist. Thank you, Carol, for helping me. I want to add a little bit more to what Dr. Meyer just said. And first of all, I want to start off by saying I completely agree with everything he said, not just the words, but also the spirit of what he's reflecting. I want to add a few things to it, and I think some of those will answer the follow-up questions that have shown up in the Q&A right now. So the first is, one of the limitations of our database, as you all know, is the lack of longitudinal follow-up, like Dr. Meyer said. So every effort to do this is going to help the community. And by the community, I mean all stakeholders, not just the physicians or the care providers or the data managers, but ultimately patients. Great example is what Dr. Meyer gave about the atrial level switches. I can give you multiple examples about that, right? Primary repair versus initial palliation, what to do with an inception cohort of tetralogy. I can give you 1,000 examples all day. So that's the why question. The why question there is really because we genuinely believe that it is these long-term follow-up data, and 1 year is not even considered long-term, but it's longer term than 30 days. So we genuinely believe as a field that this is where next progress is going to come. So I think it's crucial and important that if a patient does ask, why are you asking me? What does it matter to you, Nancy? Like you say, I think we should be empowered to answer that, because we believe that it is in the best long-term interest for us to know these outcomes, ultimately for process and quality improvement and improvement of outcomes for children with congenital heart disease. That's one point. The second point goes back to the email, Christmas card, social media that Dr. Meyer so eloquently answered. We do one additional thing. So if I see someone send me a Christmas card, or if we catch them on social media, we use the contact there to get back to them and formally establish a contact. We use it to say, hey, we're from here, glad to know things are, how are you doing? Those kinds of things. Now, the third portion goes back to one of the issues that both Janet and Nancy have raised, and that is, what are we legally allowed to ask? Now, this is going to vary with every institution. So while, yes, I agree that sharing our data tools is an important variable for all of us to get better, what you're going to be allowed to ask is going to differ based on your institution. Some institutions consent for this, some institutions don't. I happen to be at CHLA, one of the institutions where they're very strict about what we can and cannot ask. So we actually have a prospective IRB that we have signed, where we tell the family, if we get in touch with them, like I said, let's say I get a Christmas card, I call them the next day, hey, I got the Christmas card, thank you very much, glad to know you're doing well, hope things are going well with you. Hey, we'd like to get some information on how you're doing for the long term, so we keep tabs on it. Could I send you a consent form, or could you consent for us to contact your current care provider? Because like Dr. Meyer, we have a fair number of patients who are now adults. They're no longer seeing pediatricians. They may be seeing adult cardiologists or adult congenital cardiologists. And as a freestanding children's hospital ourselves, they're no longer in our system. So again, to summarize without being long-winded about it, the idea I think here is the why question, which is, we really genuinely believe that for our field to get better, long-term longitudinal outcomes is an important part of how we track patients. You're going to have to approach it in a slightly nuanced fashion based on what your resource burden that's available to you is, and what your institutional limits are on what you can and cannot do. But we really try and push the limit as much as we can to try and reestablish contact with our patients, because like Dr. Meyer, we also believe that it's the right thing to do.
Yeah, that's great, Dr. Subramanian. Thank you. I'd like to also add in, we had some in the other databases, we have to do follow-up through for patients, if they're discharged to another facility or something like that. And understanding the way that HIPAA works, accessing data for patients, as long as it's relevant to the procedure that they had, is covered under HIPAA, especially specifically if it's done for quality improvement purposes, and being part of a database is considered quality improvement according to HIPAA. So it is, it's not something that is that should require, and I realize that sites don't understand HIPAA, and some sites are hyper HIPAA compliant. But I'd be happy to share that information according to the HIPAA standards regarding the use of database following up on patients and their status according to quality, and what that means according to HIPAA. So I'd be happy to share that information. I'll have to look for it.
Yeah, I can tell you, I mean, I remember we dealt with this right at the start of, as we were really gearing up the databases. And we actually got outside legal opinion that, at least for our institution, for whatever it's worth, was enough. And this whole notion of, as Carol was explaining, if your attempts to gain information are as part of a quality improvement effort, then HIPAA doesn't apply. And so that, we've never taken the STS database, all the data submission and everything doesn't go through our IRB. Just doesn't, it wasn't deemed necessary by our institutional lawyers. So I think, that not every lawyer agrees with every other lawyer, as everybody knows. So I think that's important, obviously, for all of us to recognize, but at least there's some precedent for that. The second thing I would say is, in terms of the parents, or, what parents sort of say, why do you want to know, or something like that. I think it's important to set the expectations while they're still under your direct care, i.e. still in the hospital, or still, waiting to have their first post-operative visit, whether it's in person or virtually. So I think if one explains this in such a way that it's helpful to us as the providers, as well as a way of being able to take care of not only your child, but future children, I think our experience has been that almost everybody is compliant with that and responsive to that. So some of it is as I would say, setting the expectation up front. You can expect to hear from us, at intervals, and it's both because we're interested in your child, but it also helps us in the future take care of other kids.
Yeah, great points. And great points, Dr. Meyer. Thank you. Just a couple more questions. I missed the part of information regarding the 30-day mortality status in the audit. Did I understand it correctly that if one case is unknown, we will fail the audit? No, that is incorrect. You can code the case as appropriate, yes, no, or unknown. But what we're looking for 100% is that you have the documentation to support the way that you coded it. So for those unknown cases, that patient not being able to be reached or verified, their vital status would be documented somewhere that you attempted to reach that patient, and you weren't able to find any type of follow-up on that patient. It just has to be documented. And that documentation needs to be provided to the audit company. It's super important that you send that in on all of the cases that are being audited. And I apologize for my puppy in the background. That's Hank. And then I thought I stole all the squeaky toys, but I guess I missed one. We utilize Epic, and I use documentation from other organizations through the Care Everywhere function. Does that count as being part of the EHR? What about using vaccination dates from the state vaccination database? So for the first question about using the documentation from Care Everywhere, just Shannon, just be sure to submit that documentation. If you are chosen for audit, you need to make sure you submit all of that documentation that you used. That's Sophie. She doesn't like the puppy. That you submit all of the documentations you used for coding, especially if it came from someplace outside of your institutional EHR. The state vaccination database would be fine. And just make sure that you, again, document that that's what you used, and that's how you verified the patient's vital status. Some data managers aren't in clinical roles. This is a great point, Liz. I read your question earlier. It says some data managers aren't in clinical roles. There has to be a process in place for patient safety and reporting. If we call a patient, so somebody who may not be in a clinical role calls the patient to verify their status, and the patient has clinical concerns or that there was a death, then there needs to be a process in place to inform the clinical team and document contact in the EHR. Some of this will change our process or require additional support. So I think that should be in place anyway, since we're expecting that you're checking the 30-day status on patients. So if you are, and you're submitting that to the database, so you should already have something in place where if you do call the patient, you're non-clinical and the patient has clinical concerns, that you're forwarding those on to the appropriate person, or you're instructing that patient or patient's family to reach the physician or call 911 as appropriate, if that's the appropriate course. So hopefully, as you're doing your 30-day status already and you're marking that in the database, you're already taking those steps. And then Ashley says, just a suggestion for follow-up. We use Care Everywhere to follow up on our patients also. It's helpful for those who go to other centers, but share info this way. That's a good point, Ashley. Thank you. Any other questions? That was great conversation. And I'll be happy to share that section from HIPAA. I just have to find it. It's in one of my emails. And maybe we can share that on the next. I don't know if that would help sites in sharing information with one another, but we can certainly do that. Any other discussion, Dr. Meyer, Dr. Subramanian, Chastity, Leslie? So our next monthly webinar will be June 21st at noon Central Time, 1 o'clock Eastern, noon Central, 11 Mountain Time, and 10 Pacific. And then July 19th will be the next call after that. Thanks everybody for joining. Thank you so much to our physician leaders for joining and sharing their insights on the reasons behind long-term follow-up and their practices at their facilities to obtain it. Thank you, Chastity and Leslie and all of the team for joining. And I hope you all have a great rest of the day.
Thank you.
Thanks all.
Thank you.
Thank you.